Prakhar, you are presenting the history.
Yes, sir. Yes.
Okay, go ahead.
Okay. I am presenting the case of Mr. X, a 62-year-old Hindu male who's a resident of Noida, a retired school teacher by profession, and belonging to an upper middle socioeconomic class according to modified Kupuswamy scale. The history was presented by self and seems reliable. He presented to the OPD yesterday with chief complaints of exertional shortness of breath since past 1.5 years, multiple episodes of chest pain since past 4 months, and multiple episodes of loss of consciousness since past 2 weeks. Now, coming on history of presenting illness, patient was apparently well 1.5 years ago when he started experiencing shortness of breath, which was insidious in onset, gradually progressive, and exacerbated on exertion. Initially, the patient used to experience it while jogging and running in the morning, which he had been doing for years, and was unable to comfortably climb 3 floors to his home. But now he isn't able to do so without experiencing shortness of breath. It is relieved on resting. There is no exacerbation on postural variation and no sudden attacks at night. No history of experiencing palpitations, cough, or any seasonal variation is present. The patient also started experiencing episodes of chest pain.
Wait, Prakhar. That is it in the breathlessness?
Yes, sir. That was for breathlessness.
So the obvious question arises, which we have discussed already in the previous classes, what type of breathlessness it is?
So it's mainly exertional dyspnea, which is being presented by the patient, and on the basis of NYHA, it seems to be that like it has progressed from NYHA grade 1 to NYHA grade 2, since he is not able to
Where you have applied the NYHA grade? You have not applied any grade.
So actually, sir, we have written it in the summary. We have not mentioned it here. So we would have mentioned it also.
No, this is a summary or this is the case presentation?
Oh, sir. So this is the case presentation. Yes.
So you have to present it in a case presentation. Summary में तो करना ही है. That is all right. But in the case presentation also, that's when you come to the conclusion that whether the disease is progressive or not.
Yes,
what is the status of the breathlessness? Whether it is progressing, whether it is static, whether it is improving. Suppose a patient comes to you with a history of 1.5 years history of breathlessness and come to you with the NYHA grading 2 in the initial stage, and now it is NYHA grade 4. That means the disease is gradually progressing.
Yes, sir.
Yes, you have to apply some grade. If as this is a cardiovascular case, so you want to apply the NYHA grading. So apply the NYHA grading, number 1. Number 2 is what sort of breathlessness it is. What is the source of breathlessness? Whether it is cardiac origin, whether it is a respiratory origin, or whether it is a cardiorespiratory origin, or whether it is a non-cardiorespiratory origin. What is the source of breathlessness? Breathlessness जो आ रहा है कहाँ से आ रहा है?
So in this case, it is primarily, sir, like it is due to the cardiac cause. It's because of the low output.
Why? What is the history which is suggestive that the patient is having the low cardiac output?
So since he also has states of syncope and of angina, so it is pointing more towards cardiac cause.
Where is the syncope?
So the patient, he complained of loss of consciousness in multiple episodes. So on that basis, I am thinking it.
Please show me the slide where you have explained the syncope.
So in the chief complaints, we have the patient told us that it has the multiple episodes of loss of consciousness since past 2 weeks.
Loss of consciousness means doesn't mean syncope. Loss of consciousness is a very, very vague term. It can be anything. It can be stroke.
Yes.
All right. So
Okay.
that is a number one. That is loss of consciousness doesn't mean that the patient is having a syncope. If the patient is having a syncope, then you have to explain it in any way. If the patient is having the loss of consciousness, you have to explain it. That is the secondary thing. But my question is on the basis of breathlessness. That is your first chief complaint. We are discussing
Yes.
that. On the basis of what is the basis of breathlessness to be said that it is of the cardiac origin? What are the points in favor of the breathlessness to be in cardiac origin?
So there's
You have missed
no.
Prakhar, you have missed lot of things in the history of breathlessness. That's why you're not able to answer this question.
Okay, sir.
So what are the points which have to be mentioned during the history of breathlessness? While asking the history of breathlessness, what are the different points?
Sir, any complaint of cough, like if it would be present, then it would point to respiratory cause, if accompanied,
So
and
you have not mentioned it. There is no history of cough, or there is a history of cough.
sir, we have mentioned it, sir, in the history of cough. In the
Where
last line, there's
no history of cough, no history of cough. So that means that is against that the patient is having the cardiac origin. But what is in favor of cardiac origin?
when that it is relieved from the dyspnea is relieved from resting.
Dyspnea relieved on. Lot of noise from your side. Lots of noise.
Hello.
Not able to understand anything. Lots of noise from your side.
Hello, sir, are you able to hear me?
I'm able to hearing you, but you're audible, but lots of noise from your side. It looks like you're on a highway.
So can I answer the question?
Please fix it.
Uh, the relief on resting point to the cardiac origin of the shortness of breath.
बेटा पहले ये जो नॉइज है इसको क्लियर करो. Please fix out this noise.
So I think Prakhar is having some connection issues. I would continue till he gets back.
Okay. Go ahead.
Uh, the shortness of breath is relieved on resting. This might point towards the cardiac origin of the shortness of breath.
No. बेटा ब्रोंकियल अस्थमा का पेशेंट होगा वो भी रेस्ट करने पे रिलीव हो जाएगा. Some amount of relief is there in bronchial asthma patient also.
Uh,
What are the different points which you have to ask the patient?
uh,
I have to mute Prakhar. Go ahead, Pratik.
So we'll have to ask about the onset. How did the shortness of breath start?
मैं होकर आया हूँ अभी.
We'll have to ask about the duration. How long has the problem lasted, and how are the variation with posture? If there are So like in respiratory causes, there might be a history of exacerbation on sitting on laying down, or a history of night attacks would suggest that the cause might be respiratory. Hello, hello, hello. Am I
Hello.
audible, sir?
Yes, you are audible. Hmm. First question is the patient is having. Is this the patient is having the P&D, paroxysmal nocturnal dyspnea?
Uh, so that is what they've asked in no exacerbation on postural variation and no sudden attacks at night.
So if the patient is not having the paroxysmal nocturnal dyspnea nor the patient is having the orthopnea,
Or
so how can the
softening.
patient is having the cardiac? How can the patient is having the cardiac origin breathlessness? Hello.
Uh,
Hmm. How will you explain that the patient is not having the orthopnea, not having the paroxysmal nocturnal dyspnea, despite of that the patient breathlessness is of the cardiac origin?
mm. So it might depend on the severity. With increasing severity of orthopnea and paroxysmal nocturnal dyspnea occur in a cardiac patient.
In fact, in the initial stages of the valvular heart disease, the orthopnea and paroxysmal nocturnal dyspnea are more common.
But these are usually because of back pressure symptoms from the mitral. If there is a stenosis of the mitral wall, then we would have the back pressure changes, which would lead to congestion in the lung. But
Not the
if the
aortic valve,
problem is, so
not the
these
aortic
would be a
valve.
later. So it would also occur in aortic stenosis, but then that would be a later symptom.
No, the later symptom in aortic stenosis may be because of the hypertrophy of the left ventricle, and later on the dilation of the left ventricle. The complication of these two things may occur later stages.
Okay, sir.
Why this patient is not having the breathlessness of the non-cardiorespiratory origin? Is there any point which is suggestive that the patient does not have a cardiac lesion, does not have a respiratory lesion? Is there any history which is suggestive, or is there any history which is ruling out that possibility?
Uh, so we don't have a history to rule out non-cardiac, but the history of the three cardinal symptoms that we have is suggestive towards a cardiac origin of the symptoms like loss of consciousness, chest pain, and uh, exertional dyspnea.
All these findings may be present in the pulmonary embolism, chest
So, but
pain,
that
dyspnea.
usually it's more of an acute presentation in pulmonary embolism.
Chronic thromboembolism may also be present like this.
Yes, sir.
There should be something which is in the favor of the disease which is cardiac. Okay,
Yes,
chalo,
sir.
go ahead with the next symptom.
The patient also started experiencing episodes of chest pain accompanying shortness of breath on exertion since 4 months back, which was sudden in onset, gradually increased, compressing in character over left side of the chest, spreading into his left arm. The pain was associated with sweating, relieved within 5 to 10 minutes on resting, and didn't change with posture. No relation with meals, not associated with nausea or vomiting.
So what sort of pain it is? What type of pain it is?
So the character of the pain, radiation to the left arm suggests that it is probably an anginal pain, and the fact that it's not related with meals or nausea and vomiting rule out GERD or symptoms of heartburn.
Is it a cardiac pain? Non-cardiac pain?
The cardiac pain.
Why?
So it's accompanied with shortness of breath. It is accompanied with sweating. It is radiating to the left side, radiating to the left arm, and is relieved on resting.
So basically, it is an anginal pain.
Yes, sir.
Okay. How will you differentiate between the pain of the respiratory origin and pain of the cardiac origin?
Uh, so like pleuritic chest pain, or because the anginal pain is pretty is rather characteristic of the cardiac pain.
No. How will the pain of respiratory origin presented?
Sir, in case of pleuritis, we have a sharp stabbing pain which might be relieved on postural variations.
Relieved on postural variation.
Uh,
May exacerbate.
yes, sir.
And the most important thing is, while the patient is in inspiring position, means the patient is in inspiration. If the patient is taking deep breath, the pain is exacerbating. Most important finding.
Yes, sir.
Okay. Another thing is why this is not a pain of gastric ulcer. How will you differentiate between the pain of gastric ulcer and anginal pain?
So the pain of a gastric ulcer or of a heartburn is usually associated with nausea and vomiting, and also the radiation of the pain.
बेटा nausea vomiting के साथ में तो cardiac भी associate हो सकता है. The most important thing is the position and the character.
Yes,
What is the site of the gastric ulcer pain?
So usually epigastric.
Usually epigastric. And what is the character?
Sir, it is a burning type of pain.
It is a burning type of pain. But despite of these two features, many patients may turn out to be of the cardiac origin. But you can safely rule out in the history that if the patient is having the epigastric pain, which is non-radiating, and the pain is burning in character, maybe the pain is of the gastric origin. Okay.
Yes.
And most important, no relation with the meal.
Yes, sir.
Okay. Move forward.
The patient experienced 6 episodes of loss of consciousness on exertion in the past 2 weeks, which were preceded by lightheadedness and blurring of vision, leading to fall. The patient was caught by bystanders and didn't suffer any injury during the episode. The patient recovered after being laid flat for about 30 seconds and was able to get up immediately afterwards. No relation with meals, urination, or defecation. No history of sudden involuntary movements or abnormal posture. There were no abnormal sensations preceding the event, no passage of urine or stools, or any confusion post event. The patient has now restricted his physical activity and doesn't go on morning walk.
So do you think it is syncope?
Yes, so the episodes of loss of consciousness seem to be syncope because we have ruled out epilepsy because there were no involuntary movements or abnormal posture, nor is there a post-ictal confusion-like state because he recovers immediately after being laid flat, and also the fact that the loss of consciousness improves on being laid flat points towards the fact that the blood circulation may have been impeded, which when we lay the patient flat gets better.
Okay. Any other feature which is suggestive that it is syncope?
So it is preceded by lightheadedness and blurring of vision.
Okay. Okay, go ahead.
There is no history of febrile episodes, swelling of feet or abdomen, hoarseness of voice, no history of pain in legs while walking. We have taken this history of no pain in legs while walking to rule out that the cause of restriction of physical activity isn't because of some local lesion, but because of the systemic effect. So shall I continue?
Okay. Continue.
Past, the patient is not a known case of diabetes, hypertension, past tuberculosis infection, or epilepsy. No history of prior hospitalizations, any procedures or surgeries. No history of recurrent sore throat infections in childhood, followed by joint pain, skin nodules, or rashes. Treatment history. No history of chronic medication or any supplement or herbal medicine intake. No history of 3 weekly injections received. This we have asked because we are trying to rule out rheumatic heart disease. The patient may not remember the history of fever and sore throat, but he might remember getting injections. So we have additionally asked.
Okay.
Again, personal history. There are no similar complaints in the family. The patient is not a child from a consanguineous marriage. The patient has a vegetarian diet with no restrictions or allergies, no bowel bladder complaints reported, no excessive thirst. The patient has normal sleep, 8 hours uninterrupted, doesn't indulge in smoking or any other tobacco or alcohol consumption or substance abuse. And then we come to the examination.
General physical examination. So at the end of the history, what are your differential diagnosis?
So because of the 3 classical symptoms that we have of the exertional dyspnea, episodes of loss of consciousness, and angina, the likely causes would be aortic wall diseases. It could be aortic wall stenosis or
If you directly jump to the aortic valve disease, that means you know the diagnosis. Number 1. First, you reach the valvular heart disease, then come to the valve. If you directly said that it is a aortic valve disease, then that means you know the diagnosis prior to your examination and history.
Okay, sir.
So your first differential diagnosis is valvular heart disease, and if the examiner asks which valve, then most probably aortic valve disease.
Okay, sir.
Okay.
So if we have give a reason for how we reach the diagnosis, then can we say that the 3 symptoms that we have point towards the cardiac origin of the complaint? And
yes, first the disease it would be much better if you say the disease of the cardiac origin. Then what cardiac origin means? It is a valvular heart disease, and which valve? It may be aortic valve. If you from the onset, if you said that it is a aortic stenosis, then that means you know the diagnosis already. There is no way anyone can reach the diagnosis of aortic stenosis straight away. First, it is a cardiac origin disease, then it is a valvular heart disease. The third thing is it is of the aortic valve disease. Because there is no history which is suggested that the patient is having the aortic stenosis or the aortic regurgitation.
Okay. So can we say that the 3 complaints point us toward the cardiac origin of pain, and the complaints are of such manner that they prove that the cardiac output is reduced, or there is a cardiac function is not proper, because of which we have symptoms of hypoxia.
All these things are theoretical. There is nothing in the history which is suggestive that there is a definite history of decreased cardiac output. The only thing you can say that the patient is having the chest pain, patient is having the syncope, patient is having the breathlessness, which is most probably of the cardiac origin. So there is a possibility that the patient is suffering from disease which is related to the cardiac origin, and most probably the valvular heart disease is there. And as the patient is having the breathlessness and syncope along with the chest pain, so there is a strong possibility that the patient might have a aortic valve disease.
Okay, sir.
Okay.
Okay. Okay, sir. Thank you, sir.
So go ahead with the general physical examination.
Okay, sir. The patient is conscious and oriented to time, place, and person, lying supine comfortably on the bed. The consent for examination was obtained. The blood pressure of the patient was 122 by 84 millimeters of mercury, measured in the right brachial artery. Pressure check post 3 minutes of standing is 116 by 82 millimeters of mercury. This has been done to rule out orthostatic hypotension because of the episodes of syncope that the patient had, and because the variation in blood pressure is normal, it would suggest that the episodes of loss of consciousness were not associated with orthostatic hypotension. Then the pulse
So the
was
blood
92
pressure,
per
so the
minute.
blood pressure, so the blood pressure is normal.
Yes, sir.
Any evidence of orthostatic hypotension?
No, sir. So for orthostatic hypotension, the change should be more than 20 millimeters of mercury in the systolic blood pressure, but there is a change of only 6 millimeters of
So
mercury, which would suggest.
So that means the patient is experiencing the loss of consciousness not because of the postural hypotension. That one thing is
Yes,
ruled
sir.
out.
Yes, sir.
Okay. Why you have taken only the blood pressure in the one arm?
Sorry, sir.
There are certain diseases which can be diagnosed or uh, can be diagnosed, or differential diagnosis can be made on the basis of the blood pressure in the all four arms.
Both
If
arms.
there's a difference, if there is a difference of the blood pressure in the lower limb and the upper limb, then some disease may be diagnosed, some disease may be suspected. If the difference in the
Yes,
blood
sir.
pressure in the different arm, in the upper limb, then some diseases may be sought out, especially if you are suspecting a aortic valve disease.
Stenosis.
So
Yes,
if you are so if you are suspecting the aortic valve disease, then it is mandatory to take the blood pressure in all four limbs.
okay. So I'll take care
Why?
of that to next time.
Why
So
why
because
why blood pressure is important?
in case of if we have a supravalvular stenosis, then the blood pressure in both arms might be different.
No. The main important thing is the difference in the upper limb and the lower limb blood pressure while diagnosing
That
a
would be
case
in
of. One is the
coarctation of
coarctation
aorta.
of aorta, and what happened in the aortic regurgitation?
Uh,
What happened in the aortic regurgitation?
sorry, sir. I can't remember right now.
What is Hill sign? Anyone can write the answer in the chat box. You can write it in the chat box. What is Hill sign? Okay. So you can read that what is the Hill sign and what is the importance in the aortic regurgitation cases. That can be diagnosed while the patient, if you take the blood pressure in the lower limb and the upper limb, then you can diagnose or you can suspect that the patient might have a aortic valve disease or aortic regurgitation. Okay,
Okay, sir.
go ahead with the pulse.
The pulse was 92 per minute, measured in right radial artery, regular in rhythm. Small volume, slow rising pulse with a palpable thrill in the carotid artery. No radio-radial or radiofemoral delay. All peripheral pulses are palpable.
Okay, so the rhythm is regular. That means the patient is not in
Arrhythmia.
atrial fibrillation.
Yes, sir.
One thing is ruled out. Another thing is, what is this pulse? Is it normal or abnormal?
So it's an abnormal pulse.
It is abnormal
uh,
pulse. Why? Rate wise.
because
The
it's
rate is
a
normal or
slow rise.
abnormal?
No, so the
No,
rate
no,
is normal.
normal. So what is the normal pulse rate?
Sorry, sir. 60 to 80 is normal. This is slightly on the higher side.
Beta, wrong. You can again write it in a chat box. What is the normal pulse rate? What is the normal pulse rate? It is not 60 to 80.
80 to 100, sorry.
No, it is not 80 to 100. What is the normal pulse rate? It is 60 to 100.
60 to 100. Yes, sir.
So anything below 60 is called as
Bradycardia.
bradycardia, and anything above 100 is
Tachycardia.
tachycardia. So you should also know the causes of bradycardia and the causes of tachycardia. I will not discuss here, okay, because this is the
Yes, sir.
one of the most common question which is being asked in the examination. What are the causes of bradycardia? What are the causes of tachycardia? Okay, so go
Okay,
ahead.
sir.
Another important thing is that it is a small volume, slow rising pulse. Okay, which is abnormal.
Yes, sir.
What do you mean by
Yes,
slow?
sir.
What do you mean by small volume pulse? Small volume
Uh,
pulse का क्या मतलब है?
so that the normal volume is usually uh, so small volume is because of if the valve is stenosis, then the blood flow is reduced, and slow rising is because it takes time for the waveform to travel through a stenosis valve, which is why
बच्चे ये तो
it is
सारी की
slow.
सारी सुनो, वेट, जितनी भी ये सारी चीजें आप बता रहे हो ना, दीज आर ऑल थ्योरेटिकल.
Yes,
आप
sir.
प्रैक्टिकली कैसे बताओगे कि ये जो आपने लिखा है स्मॉल वॉल्यूम, व्हाट डू यू मीन बाय स्मॉल वॉल्यूम? स्मॉल वॉल्यूम आप कब कहोगे? आपने पेशेंट देखा, पल्स फील किया, यस,
Yes, sir. So this
and
is a
then you come to
hypothetical
the
case actually.
that is a hypothetical case, but still if you presenting the case and you find that the patient is having the small volume or the low volume, आप
Yes,
present
sir.
कर रहे हो patient is having the low volume, then how will you come to the conclusion that the patient is having the low volume or the small volume? कब कहोगे स्मॉल वॉल्यूम है, नॉर्मल वॉल्यूम है, हाई वॉल्यूम है, कब कहोगे?
Uh, uh, so this would be based on experience. When we take a number of normal pulses, then we'd know if it's small or it's, I mean, low volume or high volume.
No. These
So
are
if we
all
talk about
very basic thing. Can you please tell me what is pulse pressure?
so pulse pressure is the difference between the systolic and diastolic blood pressure.
Okay, उसको क्या कहते हैं?
So
पल्स प्रेशर जो
pulse
आपने बताया है, सिस्टोलिक और डायस्टोलिक ब्लड प्रेशर, इससे हम कैसे क्या मेजर कर सकते हैं?
the volume
कैसे?
uh,
What is the normal?
so because
What is the normal pulse pressure?
uh,
You are right in that it is the difference between the systolic and the diastolic blood pressure. What is the normal pulse pressure?
uh, 30 to 60 millimeters of mercury.
Very good. 30 to 60 is the normal pulse pressure. अगर pulse pressure normal है, if it is between the 30 and 60, 30 to 60, that means it is the volume is normal. Small volume या low volume आप कब कहोगे? When the pulse pressure is
Reduced.
less than 30.
Yes, sir.
Yes. And high volume
Yes,
when
sir.
the pulse pressure is more than 60.
Yes, sir.
All right. So
Yes, sir.
calculate your pulse, your case pulse pressure? How much it is?
So it is 36.
122 minus 84.
Sorry. Uh,
So it is 38.
38. Sorry, yeah.
So 38 is a normal. It comes between
Yes,
the
sir.
30 to 60. So how come it becomes small volume pulse? It is a normal volume pulse.
Yes, sir.
You have made it hypothetical, but you have not make the blood pressure and the pulse in synchrony of the small volume
Yes.
or the low volume. Okay.
Yes, sir.
So
Yes,
the
sir.
blood pressure should be 122 by 70 like that.
Okay, sir.
तो और बढ़ जाएगा ये तो, है ना? इनफैक्ट कम करना पड़ेगा आपको ये 110 by 70 something like that.
Yes, sir.
So that the pulse pressure should come below 30. And what do you mean by slow rising pulse? That is volume. What do you mean by slow rising pulse?
Uh, so that the peak comes later of the waveform that we feel.
But beta wave तो कहीं form हो नहीं रही है. You have to feel it and you have to see the patient. You have to palpate the pulse and then you have to tell whether it is a slow rising or rapidly rising. What do you mean by slow rising? Slow rising means बहुत धीरे से pulse feel होती है and then एकदम से die down हो जाती है.
Okay, sir.
Okay. So what do
Yes,
you
sir.
if the patient is having the low volume pulse and a slow rising pulse, what it means?
Uh, so like we have already said, a small volume means that the pulse pressure is low, and a slow
किस
rising
कंडीशन
pulse
में
would
होता है
mean
बेटा?
that.
किस कंडीशन में होता है small volume and slow rising pulse?
So this is typical of aortic stenosis.
This is typical of aortic stenosis. Now you cannot made a diagnosis of aortic regurgitation because it is polar parts. In aortic regurgitation, it is a large volume pulse and rapidly rising pulse.
Yes, sir.
Okay. Okay. Go ahead
Yes,
with
sir.
pulse के आगे चलो.
Respiratory rate 18 per minute, abdominothoracic, symmetrical chest wall expansion, temperature afebrile to touch, jugular venous pressure, seen at 2 centimeter height from the sternal angle when the patient is placed at 45 degrees to the horizontal, which is normal, neck veins not engorged, no pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema observed. The height of the patient is 165 centimeters. The weight of the patient is 60 kgs. BMI 21. The patient has a whitish complexion with black hair, good dental hygiene. No abnormality.
BMI 21 ही बनेगा 165 सेंटीमीटर और 60 kg में. Are you sure? Have you calculated it or just write it?
So,
No, have you calculated it or you have just write it?
so it would be something around 19.5.
नहीं, आपने कैलकुलेट किया है या आप ऐसे ही बोल रहे हो?
So we just wrote it.
बेटा ऐसे नहीं करना है ना. The BMI is low. 21 is low. It
Yes,
cannot
sir.
be 21. It should be 22 or 23 के अराउंड बैठेगा कुछ.
Okay, sir.
Okay. So if you are taking the BMI, so calculate it. How can you calculate the BMI?
So it's weighed by the square of height in meters.
Height in meter.
Meters.
So it is kilogram per square meter.
Meter square.
चलो आगे, go ahead.
Cardiovascular examination, starting with inspection, bilaterally symmetrical chest and no abnormalities in precaudal area or intercostal spaces. No abnormalities in spine detected.
What is precordium? You have write it precaudal area. What is precordium?
The area that corresponds to the apex of heart is called the precaudal area.
Apex. No. Apex तो नहीं है बेटा. Area of the chest which overlying the heart. पूरा heart है. It is not apex. Okay. So area of the chest overlying the heart is called the precordium. Okay. Go ahead.
Apical pulsation seen in left fifth intercostal space, 1 centimeter medial to the midclavicular line. No visible
So
pulsation seen in.
Is it normal? Is it normal or abnormal?
So usually the apical pulsation is seen just medial to the midclavicular line. So I think it would be normal.
In which intercostal space?
Fifth intercostal space.
In left fifth intercostal space. So it is normal by the location.
Location. Yes.
Location wise, it is normal. Okay.
Yes, sir. No scar marks, engorged superficial veins or sinuses seen. Palpation. Sustained apex beat palpated in fifth left intercostal space, 1 centimeter medial to midclavicular line, in left lateral position. Systolic thrill palpated in the second right intercostal.
You have wait. Why you have palpate the apex beat in the left lateral position? What do you mean by left lateral position?
So when we ask the patient to lie on the left side, and then
okay. So why you want the patient of aortic stenosis to be lie on the left side? What is the added advantage of you getting if the patient is in the left lateral position?
So it is the beat is felt better, and if there's a sustained beat, then it points towards the hypertrophy of the ventricle.
Left lateral.
Yes.
लेफ्ट लेटरल में तो बच्चे जब करने की जरूरत होती है जब आपको नॉर्मली पैल्पेट ही नहीं हो रहा है एपेक्स. What are the causes of non palpable apex? If you are not able to palpate the apex, if you are not feel the apex, what are the differential diagnosis? What are the causes?
So it can be cardiac tamponade.
Good.
It can be a massive pleural effusion.
Marked pleural effusion, left-sided pleural effusion.
Yes.
Right-sided में तो कोई फर्क नहीं पड़ेगा. Active left-sided pleural effusion. Good.
Dextrocardia.
Dextrocardia.
If because of if the patient is very obese.
Obesity. Yes.
And in cases of heart failure.
In cases of heart failure.
And
yes.
So that is all I know right now.
The another possibility is that the apex is lying just behind the ribs.
Okay.
Okay.
Okay, sir.
Only in that situation, if you keep the patient on the left lateral posture, then you can feel the apex beat. Otherwise, in the causes which you have mentioned, if you put the patient in the left lateral posture, then the apex beat will not be palpable, neither in
Okay, sir.
obesity nor in the um, cardiac tamponade or massive pleural effusion. Okay, so there is a possibility that if the patient is having the apex beat is lying below the that bony part, then you cannot feel it. And if the patient is kept on the left lateral posture, then the apex beat can be felt. Okay, the second thing is the sustained apex beat. Now, what do you mean by sustained apex?
Uh, so usually it means that it's continuously palpable, which means that the heart might be uh, the ventricles might have hypertrophy, because usually we just feel the pulse once in the cycle, and on palpation we can feel it once. But if there is a continuous sensation of heart, then that is known as the sustained apex beat.
अच्छा, what do you mean by sustained apex beat? Theoretically बताओ क्या होता है theoretically sustained apex beat?
So it usually points towards the left ventricular hypertrophy.
No, what do you mean by sustained apex beat? When do you say that the apex beat is sustained? It is not ill sustained. The other name of the sustained is the heaving.
Yes.
And ill sustained means hyperdynamic. Now tell me, what do you mean by sustained or heaving, or ill sustained or hyperdynamic?
Sir, I don't.
Okay, if anyone knows, please write in the chat box. Okay.
Yes, sir.
Hyperdynamic apex beat means, in terms of theoretically, there's an increase in the amplitude without increase in the duration. While in sustained or the heaving apex beat, there's an increase in the amplitude as well as the increase in the duration of the impulse. To be more precise, sustained apex beat, the apex beat goes more than the one third to 2/3 of the apex beat. So
Okay,
if
sir.
there is an increase in the amplitude as well as the duration of the impulse, then it is called as a sustained apex beat.
Okay, sir.
Okay. So the next thing is the systolic thrill. What do you mean by systolic thrill?
So thrill is a palpable murmur, and systolic thrill means it comes in the
Now,
systolic phase.
how you come to the point that it is a systolic thrill?
So we'll be taking the pulse simultaneously. Only then can be comment on
Pulse
whether it is
simultaneously means I'm not getting your point. आप कब कहोगे कि ये सिस्टोलिक थ्रिल है या ये डायस्टोलिक थ्रिल है?
So if it's with the apical pulsation, then it would be systolic thrill.
Apical.
Because that would suggest that it is coinciding with the systole.
Okay, so that means first you have to identify whether this is in the systole or in the diastole.
That's it. Yes, sir.
Okay, so when will you say that it is a systolic event? What is systole? Theoretically, nahi, practically.
So
any event which comes between the first heart sound and the second heart sound is a systolic event. But in palpation, one cannot palpate the first heart sound in the normal situation. If the first heart sound is palpable, then it is called something else. So normally, first heart sound is not palpable. So आप कैसे कहोगे कि ये सिस्टोल है कि डायस्टोल है?
So we can we can check the peripheral pulse and see with that if it is coinciding with that.
नहीं बेटा, नहीं कोइंसाइड नहीं करना ना. अगर कोइंसाइड हो गया तो फिर तो वो डायस्टोलिक इवेंट भी हो जाएगा.
Just before the peak of the carotid pulse, if it is coming then.
And the carotid pulse के साथ में जो corroborate हो रहा है, that is the first heart sound.
Yes, sir.
Yes or no?
Yes, sir.
So how will you say that this is the systolic event or the diastolic event? You can only say with the use of stethoscope.
Okay, sir.
Because by the use of stethoscope you can identify the first heart sound and the second heart sound. Okay.
Okay, sir. Yes, sir.
Yeah. Go ahead.
So no other thrills palpated, percussion not performed. Auscultation, heart rate 92 beats per minute in sinus rhythm. S1 audible and unremarkable. S2 shows reverse splitting at end expiration. A mid-systolic murmur.
What do you mean?
Rough.
What do you mean by reverse splitting?
So normally the second heart can be physiologically split, but in the physiological splitting, the splitting occurs at inspiration and not at expiration. Because
so what are the different components of that? What are the different components of S2?
So there are two components of S2, A2 and P2, which are the aortic and the pulmonary components.
So normally, what is the physiological splitting?
Sir, A2 precedes P2 usually. And at the inspiration, we can identify the splitting, while at the expiration, it might be difficult or it might not be there. And because in this case, the split is occurring at expiration, it is called the reverse of paradoxical splitting.
Reverse
or paradoxical splitting.
Okay, that means P2 comes ahead of A2. What do you want to say? You want to say this?
Yes, sir.
What are the other conditions in which this reverse splitting occurs? How can you palpate the A2 and how will you palpate the P2?
That I don't know, sir.
If you don't know how to palpate A2 and how to palpate P2, then how can you comment on the splitting and the reverse splitting?
So this is the auscultation finding.
Yes. In auscultatory findings, you have to identify, okay, this is the A2 component and this is the P2 component. Then you can say, okay, A2 come first or the P2 come first, or the P2 preceded the A2. If there is a splitting or there is a reverse splitting, if you don't know how to palpate, how to auscultate the A2 and how to auscultate the P2, then how can you comment it on the reverse splitting or the splitting?
So in auscultation, the different the areas corresponding to the walls is where we usually hear the sounds the best. So if
that's what I am asking. That's what I am asking. How will you auscultate the A2 component and how will you auscultate the P2 component? आप A2 को और P2 को कैसे palpate करोगे और कैसे बताओगे ये जो हमें दो साउंड सुनाई दे रही हैं ये A2 है या P2 है?
So the A2 is best heard in the aortic area, which is in the second right intercostal space, just lateral to the clavicle, which is the aortic area, and the pulmonary is in the second left intercostal space. So where the sounds are the loudest, the given sound is the loudest, we can say that it's the aortic or the pulmonary sound.
And when you say it's reverse, that means P2 comes first.
Yes,
Then
sir.
how can you how will you assess that the P2 is coming prior to the A2?
So the sounds are different in character also, which helps us in differentiating between the aortic and pulmonary sounds.
नो आप A2 को P2 से डिफरेंशिएट कर रहे हो तो कैसे बताओगे कि रिवर्स हो गया है कि P2 पहले आ गया है? क्या फाइंडिंग्स होंगी उसमें? Then only you can say na that this is the reverse splitting.
Yes, sir.
So first of all, at the undergraduate level, we do not expect you to comment on the splitting or the reverse splitting. Splitting karna hai, that is all right. But reverse splitting, we actually don't want you to comment on that because we don't expect reverse splitting to be heard by the UG student. So if you are not sure how to auscultate the A2 sound and the P2 sound, then please don't mention the reverse splitting. Because if you mention the reverse splitting, then automatically the question may arises. Okay?
Yes, sir. Yes, sir.
Okay. Go ahead with the murmur.
Grade 4/6, radiating upwards towards, the mid-systolic murmur, rough and rasping.
Mid-systolic murmur. Now, what do you mean by mid-systolic murmur? What do you mean by mid-systolic murmur?
Sir, a mid-systolic murmur is the one which has the highest amplitude in the middle of the systole.
So basically it starts after the first heart sound and the murmur completed before the second heart sound. That is the most important thing. First heart sound के बाद में शुरू हो रहा है और second heart sound से पहले खत्म हो रहा है. That is mandatory.
Yes, sir.
Okay. If it is continued till the second heart sound, then what it called?
Hollow systolic murmur.
What do you mean by hollow systolic murmur?
So
What is hollow
pansystolic
systolic? Pansystolic or hollow systolic. And if it is angle the S2 means S2 के बाद भी continue हो रहा है, then it is called as? Good.
That I don't know, sir. Sorry.
That is called the continuous murmur.
Oh, okay, sir.
Okay. If the S2 is also engulfed and the murmur goes beyond the S2, then it is called as continuous murmur, and that is typical in patient of PDA. Okay.
Okay, sir.
चलो
Okay,
आगे.
sir.
Mid systolic murmur, rough. हाँ आगे बताओ.
Rough and rasping, heard best with the diaphragm of the stethoscope in the
ये
aortic
rough and
area.
rasping क्या चीज है? What is rough and rasping?
So it means that it's rough or metallic kind of sound that we get from the
Metallic. If you said metallic type of sound, that simply means the patient is having the prosthetic valve. Metallic sound simply means prosthetic valve. If you use the term metallic, I think you want to say it is harsh murmur.
Yes, sir.
Don't use the term metallic. Metallic simply means the prosthetic valve. Okay. Best said with the
diaphragm of the stethoscope in the aortic area, with patient sitting and leaning forward, peeking towards the middle of ejection and ends before S2.
Why you make the patient sitting and lean forward in a sitting posture and the leaning forward posture?
So this is a maneuver which helps in appreciating the murmur better.
Why? What is the advantage of keeping the patient in sitting and leaning forward position? In a sitting and a leaning forward posture, the aortic valve comes near to the chest wall.
Okay.
आपने पेशेंट को बिठाया हुआ है. Lean forward means you have asked the patient to bend down. So when the patient is
Yes, sir.
in a lean forward position, the aortic valve come closer to the chest wall. So the murmur or whatever activity is going on at the level of the aortic valve is appreciated better in the sitting and the leaning forward position. That is the same thing which happened in the mitral valve cases. The patient is in the left lateral posture. In the left lateral posture, the apex comes closer to the chest wall. The mitral valve comes closer to the chest wall. So the murmur or whatever activities is going at the level of the mitral valve is appreciated better in the left lateral posture. And the same thing applies here. The aortic in the aortic valve region, if the patient is in sitting posture or the patient is in leaning forward position, the aortic valve comes close to the chest wall. Okay.
Okay, sir. Thank you, sir. Grade 4/6, radiation upwards towards the carotid. Grade 4 or higher murmur is accompanied by a thrill, and that is why it's grade 4. After that, the murmur increases in intensity on expiration, squatting, and exercise, and decreases on strain phase of Valsalva and standing. The murmur is preceded by ejection click. So shall I continue?
Hello.
Hello. So shall I continue?
Yes. Your cardiovascular examination finished?
Yes, sir.
So no murmur. Auscultation पे जाओ. Go to the auscultation part.
Yes, sir.
What about this murmur increase in intensity
So
with
this,
expiration, squatting and exercise, and Valsalva maneuver?
yes, sir.
तो ये तुमने किए तो होंगे नहीं कुछ
Decrease
भी.
by, sorry,
Just read down the about the maneuvers and the pathophysiology behind it.
Sir, I did read up a little. It is like the all the maneuvers which increase the left ventricular either contractility or end diastolic volume would increase the murmur intensity in this case, and the ones that decrease it would decrease the intensity of the murmur, which is why on standing like the.
What is this ejection click?
Sir, ejection click usually.
What is click? What is click? What do you mean by click?
So it is a single sound because of the opening of the aortic valve.
Okay.
And it is usually heard after S1, and that is how we identify that it is probably because of the opening of the aortic, which marks the start of the ejection.
What happened to the click with inspiration or the aspiration? Is there any relation with the inspiration and the expiration? No. Don't worry. We don't expect click to be heard by the UG student. Okay. If you really heard the click, then you can comment over the click. If you don't know about the click, don't mention it.
Okay, sir.
Okay. Okay. Go ahead.
Yes, sir. Nervous system examination. The patient has good memory, normal intellect, speech and following commands, no sensory, motor, gait, and discipline.
Okay. Go ahead.
Respiratory examination. The chest is bilaterally symmetrical and elliptical with thoracoabdominal breathing, no use of accessory muscles. 7 centimeter chest expansion, symmetrical. Bilateral vesicular breath sound heard, no adventitious breath sound heard. Abdomen examination, symmetrical, non-distended. Umbilicus is in midline and inverted, no visible scars, swellings, engorged veins or scratch marks, no raised temperature and tenderness on superficial or deep palpation, no hepatosplenomegaly, the percussion is tympanic, and then we have the summary. Mr. X, a 62-year-old male, presented with gradually progressive shortness of breath since past 1.5 years, progressed from NYHA 1 to NYHA 2 during the course of the illness, multiple episodes of exertional chest pain and exertional syncope since 4 months and 2 weeks respectively, with no significant past family, drug, and personal history, has a sustained apex beat in the left fifth intercostal space, 1 centimeter medial to mid-clavicular line, a slow volume, slow rising pulse with systolic thrill palpated over the aortic area radiating towards the carotid, unremarkable S1 and reverse split of the S2 heard in end expiration, a mid-systolic crescendo-decrescendo murmur radiating towards the carotid preceded by ejection split heard over the aortic area, and unremarkable respiratory findings. The provisional diagnosis. My patient, Mr. X, is a case of valvular aortic stenosis of non-rheumatic origin without congestive cardiac failure and presently in sinus rhythm. So that is the PPT.
So at the end of the history and the examination, what are your differential diagnosis?
So the differential diagnosis would be
You have directly made the diagnosis. That's what I am asking. What are the differential diagnosis? You have not mentioned the differential diagnosis. You have made the diagnosis. What is this provisional diagnosis? Summary is all right. Summary is all right.
Yes, sir.
No problem with the summary.
So is valvular aortic stenosis non-rheumatic?
Why it is valvular aortic stenosis? Why this is not a congenital aortic stenosis? What is the age of the patient?
62 years, sir.
62 years. Why it is not a congenital subvalvular aortic stenosis or supravalvular aortic stenosis?
So because the congenital usually presents earlier, and the supravalvular disease is usually also accompanied by the
No, finish it first. Finish the one type first and then go ahead to the second one. You are talking about the congenital. What is the main
Yes,
feature of the congenital subvalvular aortic stenosis? What is the main problem with the congenital subvalvular aortic stenosis? What happened in the congenital? What is the congenital anomaly occur in the subvalvular aortic stenosis?
Usually it is a bicuspid valve, aortic valve.
No. It is bicuspid aortic valve नहीं होगा बच्चे. The membranous diaphragm or the fibrous ridge just below the aortic valve.
Yes, sir.
Is present in the congenital, and the most important finding is the asymmetrical hypertrophy of the interventricular septum. That's why it is also called as the idiopathic hypertrophic subaortic stenosis. Okay,
Okay, sir.
that's why it is, as there is a fibrous band in or the hypertrophy at the subaortic area. इसीलिए इसको, that's why we called it subvalvular aortic stenosis. What happened in the supravalvular? You understand the terminology supravalvular and the subvalvular. Subvalvular means नीचे, supravalvular means valve के ऊपर.
Yes, sir.
What happened in the supravalvular aortic stenosis?
Sir, there are two kinds, I guess. It could be a simple hourglass deformity, or the other kind is when we have a generalized narrowing of the...
बड़ा सिंपल सा क्वेश्चन है. सुप्रावेल्वुलर एओर्टिक स्टेनोसिस में कहाँ प्रॉब्लम होती है?
Sir, about the usually in the root of aorta or
Ascending aorta. भाई
ascending aorta.
as the name suggests supravalvular. Supravalvular मतलब aortic valve के ऊपर. Aortic valve के ऊपर क्या है? Ascending aorta. So there is a
Ascending.
narrowing of the ascending aorta or by the
Dilatation
fibrous diaphragm.
beyond the.
Can anyone knows what is Williams syndrome? आप बताओगे प्रतीक विलियम syndrome क्या होता है?
Yes, sir, it is there is a supravalvular stenosis, Elfin facies, and so these are the two characteristics I remember.
The mental retardation is there and the patient is having the hypercalcemia. These are the four things which are present in the Williams syndrome. Williams syndrome is important because not in the UG exam we expect it, but in the postgraduate examination we expect the patient to diagnose whether if the aortic stenosis of the supravalvular side will it be a Williams syndrome. Then in that case the student has to take the history of the regarding the faces and the mental miniatures. So the student had to do the minimata scoring to rule out the supravalvular aortic stenosis. Okay.
Okay, sir. Yes, sir.
So non-rheumatic origin. Why this is non-rheumatic origin?
So because in the history we had asked about the episodes and also the medication, so it's more likely that it would be non-rheumatic.
Okay. Without congestive cardiac failure and presently patient is in the sinus rhythm. One more thing has to be added in the diagnosis is the without any evidence of the infective endocarditis.
Okay, sir.
Okay.
Yes, sir.
What are the complications of aortic stenosis? Complications क्या हो सकते हैं पेशेंट को अगर ये पेशेंट आपके पास में आया if the patient is not treated in time, what are the complications of aortic stenosis?
So if untreated, it can also be fatal, like usually untreated. And then we can have
what is the most common complication of aortic stenosis? सिंपल है भाई. कहाँ पर प्रॉब्लम हो रही है? aortic valve पर. aortic valve के आगे क्या है? aorta.
ascending aorta.
उससे पहले क्या है? लेफ्ट वेंट्रिकल. तो कुछ भी फर्क पड़ेगा कहाँ पड़ेगा? Left ventricle. So left ventricle failure is the most common complication, followed by the congestive cardiac failure. Then arrhythmia may be there, infective endocarditis may be there, and especially in patient of aortic stenosis, angina may be precipitated.
Yes, sir.
Okay, so these are the complication of aortic stenosis.
Yes, sir.
Okay.
Yes, sir.
Anything else you want to ask? Any
so
query,
like,
any question?
So on the basis of history, any other factors that might be pointing towards the lesion being at the valvular level, not at the subvalvular or supravalvular level?
See, there are certain points which you can differentiate that the patient is having the subvalvular aortic stenosis or the supravalvular aortic stenosis. If the patient is suffering from the subvalvular aortic stenosis, then obviously the dyspnea, angina, fatigue, syncope, these are the major symptoms which may be present also in the supravalvular aortic stenosis. But in subvalvular aortic stenosis, most of the time the apex beat is the double apex beat, number one. Many times you feel two apex beat. Second thing is that the carotid artery pulse is usually of the rapidly rising type. Okay.
Okay, sir.
It is
Okay,
not
sir.
the slow, it is not the slow rising type like the that valvular type. Okay. Many time it is the double pulses. Means when you feel the pulse, the double pulses may be feel. It is also called as the pulses dysperience.
This is okay, sir.
Okay. Okay.
Yes, sir.
And in cases of the supravalvular aortic stenosis, blood pressure is very important. There is a unequal blood pressure in the both arms.
Oh, yes.
Okay. And
So this would
supravalvular
be
aortic,
because of the.
because the
So
lesion
this
is
would be because
the
of
lesion is
subclavian.
above the aortic valve, above the aortic valve.
Okay.
So there is a inequality in the blood pressure in both the arms.
Okay, sir.
Okay. And another thing is that um, the thing is we do not expect undergraduate student to hear the click, but the click is the one of the major differentiating feature between the supravalvular and the subvalvular. In cases of the supravalvular aortic stenosis, we do not expect the click to be heard. Only murmur
Okay,
is
sir.
there. Only ejection systolic murmur is present in the supravalvular aortic stenosis. While in cases of the subvalvular aortic stenosis, ejection systolic murmur is usually present, and it is more harsh, it is more louder, and many time uh, early diastolic murmur of aortic regurgitation may also be heard in patient of a subvalvular aortic stenosis. Okay.
Okay, sir.
Usually we do not
Thank you,
expect
sir.
you to differentiate between the subvalvular and the supravalvular in terms of a click. Okay, the blood pressure, yes. The symptoms, yes. And the pulse. These are the three things. If you able to differentiate the if you able to tell the features of these three things in the differentiation of the supravalvular and the subvalvular, that is acceptable. So
Okay,
anything
sir.
else you want? Anything else you want from my side?
So what would I'd also so what would be the investigations like? We would do an O2 check the status of the valves and
See,
the
the
grading activity.
any patient comes to you with the valvular heart disease, obviously you go for the ECG, you go for the X-ray chest, and the most important thing is the echocardiography. Echocardiography will tell you everything: the left ventricular enlargement, the hypertrophy, the calcification, the valve position, the ejection fraction, the wall of the ventricle, the pliability of the valve. All these things can be assessed by using the echocardiography. Okay.
Yes, sir.
And if you are suspecting the infective endocarditis in that patient, then obviously echocardiography along with the blood culture is mandatory to establish the diagnosis of the infective endocarditis.
Okay,
Okay.
sir. Yes, sir.
Okay. So if there is no question from your side, then I can take the question from the chat box. So the
Oh,
questions
so should
are,
I stop sharing my screen?
hello.
So should I stop sharing my screen now?
Yeah, you can do that.
Okay. Thank you, sir.
Pink frothy sputum. Pleuritic chest pain increase on inspiration. Swati Yadav. Yes. Peptic ulcer pain is increased on food intake. Yes. Femoral Class. Water hammer pulse. Difference in systolic blood pressure of more than 20 between the upper and the lower limb. Yes, most of you are writing right answers. What is this? 60 to 100. Okay, this is pulse. Yes, the normal pulse rate is 60 to 100, which I already explained. Anything below 60 is the bradycardia. Anything above 100 is the tachycardia. Sakshi, 60 to 90 is wrong. It is 60 to 100. Basically, there is no question. I am not able to see any question. The only queries, the only answer, the only chat is the answer of my question. Okay, there is one question. Shubham, how long and how much practice does it take one to appreciate such fine things like murmur occurring in early, mid, or late systole? Okay, the answer to this question is very simple. At the undergraduate level, we only expect you to identify whether this murmur is a systolic murmur or a diastolic murmur. That is very simple. You have to corroborate the systolic or the diastolic event with the carotid artery, the pulsation which is corroborating with the carotid artery is the first heart sound. So anything after the first heart sound is a systolic event. Anything prior to that is a diastolic event. If you able to know what is systole and what is diastole, what is systolic murmur, what is diastolic murmur, that is sufficient to pass your UG exam. Coming to the early, mid, or late diastolic murmur, if the patient is in tachycardia, means if the let's say pulse rate of 120 or 130, then it is very difficult to anyone how much experience the person is. It is very difficult to identify that the murmur is the mid systolic or the late systolic or the late diastolic, and in that situation it is very difficult to even identify the systolic and the diastolic event if the patient is having the massive tachycardia. If the patient is in the normal sinus rhythm, if the patient is having the pulse rate, let's say 70 or 80, then yes, with the experience, you can identify the murmur being you can gauge the murmur in terms of a mid, early, or the late systolic or the diastolic event. But yes, if the patient is having that pulse rate of more than 110, 120, then it will be or the patient is in atrial fibrillation, then it will be very difficult to identify to gauge the timing of the murmur. So there is no other question. So with that, I would like to thank all the two presenter, Prateek and Prakhar, for presenting the cases, and also thank all of you to come and who have come and joined the class. Now I will leave this session here. I will end this session here. Thank you very much for the attending the class.